slipped into clinical medicine by dint of meeting a student on your summer course in the United States who persuaded you that clinical psychology would be a good thing to do. And you took to it and have flourished in it ever since. You are an amazingly distinguished practitioner, and during the pandemic you actually co-chaired CoSpace, which was the research program which tried to create an understanding of how young people were responding to the pandemic. You have published, or rather edited, a very important book on compulsive disorders amongst adolescents. And most recently, you were elected a Fellow of New College. And in that role, you add a clinical dimension for our psychology students. And I know they all love you.
Oh, that's very nice to hear.
And I also know, from my point of view, that you're an extremely welcome addition to the friendship, bringing lots of good feelings and freshness into our fusty body. So without any more ado, the rise of childhood anxiety problems, what can we do?
Thank you very much. Thank you for that lovely introduction, Miles, and thank you so much for coming to attend this talk. It's such a pleasure to meet you all, so thank you. So I'm going to be talking this evening about the rise in anxiety in young people. Anxiety is one of the most common clinical problems that we see in this population, and of course, if it occurs in your childhood, that's a particularly problematic time. It's such a formative time of development where you're developing friendships, developing relationships, becoming increasingly autonomous, studying for exams. As we know, we're right in the middle of GCSEs and A-levels now that are going to be really important in directing your future career. So to have a problem with anxiety at that point is really problematic for young people. And I'm going to be talking a little bit tonight about the rise that we've seen in Western and in Westernized countries, and really thinking about how we might explain it, and then thinking about what we might do. And within that, I'm going to be talking about some of the research that we've been doing in Oxford to try to develop more targeted and effective interventions for dealing with anxiety problems. But I thought what I might start by doing is just giving you a sort of flavour, because I think we all think we know about anxiety because it's such a common experience. But I want to start with a quote of a young person who we treated within one of our trials who experienced anxiety. So this is a young person with panic disorder, and this is her describing that kind of experience as she's having a panic attack. So she says, at first I struggled to breathe, and then I felt like I was going to faint on the floor. It was terrifying, and I was just panicking, and I just kept like trying to hold on to my mum and like squeeze her. I didn't understand what was going on or why I felt that way. So I was confused as well. I thought I would die. I'm trying to hide what's going on, but I can't. Because in the moment you want to scream, you can't breathe, you're freaking out, but obviously you don't want anyone to stare at you or to realise what's going on, because obviously they won't understand what's going on. And that kind of makes it worse, because while you're trying to manage a panic attack, you're also trying to look like you're not having one, because you don't want people's judgment, and even afterwards you're embarrassed because everybody just saw you freak out. So you can imagine for young people like this, it's having a huge impact on their school life and on various different aspects of their life experiences. And early intervention is really important because we know that anxiety disorders occur early on in life. So 52% of anxiety and fear-related problems start before the age of 18, and nearly 3/4 of them start before the age of 25. So if we can get in there early, we have a really good opportunity to try to really change the trajectory of a young person's life. So let's start to think about this idea of have they increased. So this slide you can see here, this graph, comes from NHS Digital. And this comes from a survey that NHS Digital conducted first in 2004, and you can see the black line there from 2004, and then in 2017 as well. And this is really excellent quality data because this study involved going out to the general population. So it wasn't about people choosing to take part and choosing to report. They went to the community population using a representative sample of thousands and thousands of children in the UK. And then they did a diagnostic interview with these young people to try to understand what they were experiencing across a range of dimensions, not just anxiety. And that was based on the report of the young people, of their parents and teachers where possible too. And so what you can see here is if we look at 2004, you can see that there's an increase from 5 to 10 years old to 11 to 16-year-olds. But then when we look at the blue line, you can see that actually we've got higher prevalence data when we look at this more recent line. And what you can also see that anxiety disorders not only appear to have increased over time, but they increase through childhood and adolescence. So as you get older, your risk of developing an anxiety disorder increases. And sadly, we don't have further diagnostic data from NHS Digital, but they have continued to do some follow-ups, this time using questionnaire data. So we don't have quite that same level of information. But what that showed since the pandemic, so obviously 2017 is pre-pandemic, is that actually, if anything, the rates have gone up since then. So we're now at a point where, on the basis of this data, it looks like 1 in 5 children and young people have a probable mental disorder, such as anxiety and depression. So all of that gives us some indication that they may have increased. Now, that's not the case across the board with all mental health difficulties, which is interesting. So when looking at this data for behaviour disorders, actually there's no increase at all, and we don't see rates of things like ADHD increasing over time. So it seems to be something that's particular to these emotional disorders. And that's corroborated in some ways by other data that we've got. So we know, for example, self-harm presenting to accident and emergency departments has increased, and we also know something about mental health referrals into child and adolescent mental health teams has also increased. So whilst people seem to be better at understanding and reporting anxiety, we're also seeing what we think looks like a more genuine increase over time, over this last sort of 20 years. But of course, it's important at the outset to recognise that anxiety is absolutely normal, and all of us will experience anxiety from time to time. Here are just a range of different things that we might all experience at different times, worries in all of these domains. And of course, we're right in the thick of GCSEs and A-levels, so for parents and young people themselves, I would imagine education, work, all of those kind of things are going to be really, really on their minds. I have a child doing GCSEs and a child doing A-levels right at this very moment, so I can certainly identify with some of this. So we know absolutely that it is normal. And in some instances, of course, facilitative of doing well. If you are worried about something and you really want to do well, perhaps that might encourage you to do more revision and to be as best prepared as you can. But of course, we know for other people it's not facilitative, and it actually gets in the way and stops you being able to do the things that you need to do to be effective. So when we're thinking about anxiety, we're really thinking about it on this continuum. So essentially, we've got low levels all the way up to high levels of symptoms, recognising this idea that actually we all experience it. But of course, ultimately, we need to have some kind of cut-off so we can make sense of those that are just experiencing a normal developmental stress versus those that have a problem that needs treatment. So where we're thinking about people that actually at that clinical level that have an anxiety disorder. And when we're thinking about anxiety disorders, we're thinking about people that have high levels of symptoms that persist over time. So of course, during periods of time, you're going to be really stressed, but we're looking at that extending over weeks and beyond. But we're also importantly looking for symptoms that cause significant levels of distress and significant levels of impairment. So that might be getting in the way of things like going to school, attending lessons, spending time with friends. It might involve difficulties with your sleep, difficulties in family life. So we're really looking at that kind of level if we're thinking about a disorder. Now, one of the challenges we have, I think, over the last decade or so is that young people are so much better versed in the idea of mental health. They have so much more information, and mental health awareness campaigns have done a good job in many ways of destigmatizing mental illness. But of course, one of the other challenges we have now is very many young people identify with mental illness for whom actually that may not be the case. And one of the challenges that I think all of us can experience is that young people are using the terms of mental illness when that may not be what they're actually describing. And that is a huge challenge for all of us because it means that those milder symptoms are conflated with more severe symptoms. And certainly one of my colleagues, Lucy Folks, in Oxford is doing a huge amount of work in this area, really trying to help us think about how we might manage that particular challenge. So what do we mean by anxiety disorders? We often talk about this term very loosely, but of course there are multiple different kinds of anxiety disorders. So the range includes these different disorders. So we've got, first of all, separation anxiety. So that's the idea of somebody finding it difficult to be apart from someone. It's really prevalent in younger children in particular, where they might worry about being apart from a parent or a caregiver, might worry that something bad will happen to that person when they're away from them, or perhaps something bad might happen to them. It can make bedtimes horrible for parents and children because of that period of separation. And then we've got generalized anxiety, which is very common, and that's where people worry excessively about a range of different things. So that earlier slide I showed you with all of those different areas could be about all of those different things, more days than not, for around 6 months or so. Often that can make things like sleep really challenging. And then we've got social anxiety, where people worry a lot about what other people think. They worry about embarrassing themselves or being humiliated, and they worry about that sort of negative evaluation from other people. Phobias, incredibly common. So we see very often in younger children, might see animal phobias like dog phobias or wasp phobias, whole range of different things. In teenagers, we see vomit phobias very commonly, as well as things like blood injury and injection phobias. So phobias tend to vary quite a lot over time. Many of them, may not need high levels of sort of input. They're actually incredibly treatable. And then we've got panic disorder. So panic disorder is when people experience recurrent panic attacks, a bit like we were seeing in that very first slide. But for panic disorder, the person needs to worry a lot about having further panic attacks, and they need to change their behaviour to try to prevent having further panic attacks. And OCD used to be classified as an anxiety disorder, but actually in the last iteration of our diagnostic and statistical manual that separates all the disorders, it got moved out of anxiety. So it's very related, but it's not actually now described as an anxiety disorder per se. So anxiety disorders do vary by age, and when I started doing research in this area, because I'm particularly interested in teenagers, I was really interested because often studies treat children and adolescents as this one great big homogenous group. Lots of studies involve looking at them across the age range without really trying to disentangle, what's different about childhood and adolescence. So early on, one of the studies that we carried out was looking at 100 consecutive referrals of children being referred into child and adolescent mental health services in the NHS, CAMS, and 100 consecutive referrals for teenagers to see how they differed. And actually they differ in many different ways, but not least of all in the kind of anxiety problems that they experience. So if we look at the darker blue bars for our teenagers, you can see that social anxiety is our number one primary anxiety disorder we see at that age. I think that probably comes as no surprise to any of you if you remember your own teenage experiences or you have teenagers yourselves. And it's, to some degree, it's very normative to have social anxieties at that time in life where you're very focused on your peers and what other people think, lots of things going on neurologically that really prime you for that. But for here, we're talking about when it goes beyond that level. And then, of course, we see generalized anxiety, so there's just pervasive worry being very high, specific phobias, and then panic. But in our children, we see quite a different pattern. So we still see high levels of generalized anxiety, but we see lots more separation anxiety, as I mentioned earlier. And we really don't see panic disorder, actually, in younger children. They might have very panicky feelings, they might have panic attacks, but they don't tend to worry a lot about having further panic attacks. And that's probably reflective of that kind of cognitive development as children move into adolescence and start to reflect a bit more on their symptoms. So one of the things I was interested in is thinking particularly about teenagers and making this comparison. So as I've mentioned, we see different kinds of presenting problems, but actually we do see more severe anxiety overall. We tend to see them more frequently experiencing low mood alongside that anxiety. And of course, inevitably, we see greater problems in them not being able to attend school as a result of that. So there is something particular about teenagers that we definitely need to take into account when we're thinking about treatments. So when we're thinking about anxiety, there are particular biases that we tend to notice. So anxiety is all about future threat when we're thinking about it. In contrast to depression, where often you're ruminating about things that might have occurred in the past, anxiety is all about the future. And a core feature of anxiety is just this selective bias that we have when we feel anxious in a number of different things that we tend to do in the way that we might fixate our attention. So for someone with social anxiety, they're going to be much more tuned in, really on the lookout for how other people might be sort of thinking about them. Perhaps scanning faces to see whether people are frowning, whether people are smiling, but they're going to be really tuned in the way that they pay their attention. in the way that someone with OCD is going to be really noticing, you know, if you have a contamination fear, you're going to be noticing everything that everyone touches. So as soon as we get into anxiety, people have zoned in attention where they're hypervigilant for particular things. And then when faced with ambiguity, when we're anxious, we tend to interpret things in negative ways. So for someone in a social situation where they've got an ambiguous response, the person maybe has a fairly neutral face, they may start to interpret it in a particular way by thinking the person thinks I'm stupid, they think I'm boring, you know, all of those kind of things. And then in anxious situations, people tend to then recall events that fit, that are consistent with the way that they're feeling in that moment. So they might remember, you know, an embarrassing thing that happened at school. Perhaps they put their hand up, they said something, everyone laughed at them. Those kind of things tend to get invoked really easily. So we can see that we've got these particular cognitive biases that become magnified in anxiety disorders. And compounding that is this idea of behaviour. So avoidance is the hallmark in terms of behaviour when we're anxious. And we can probably all relate to that, can't we? You know, you've got a phone call, you know you need to make it, you just keep putting it off, finding another thing to do before you go and make that phone call. And we see this being a pervasive problem in anxiety disorders. So actually, these behaviours are typically done by people with the idea that they're going to, you know, stay safe. So they might do a number of different things to try to protect themselves, because if they believe something's going to go wrong, for example, that they're going to be rejected by someone if they chat to them, then it makes sense that they might do lots of different things to try to make that situation as safe as possible. Perhaps they don't say too much personal information. Maybe they plan everything they're going to say before they go into the situation so that they know that they've got lots of things to talk about. So all of these very effortful behaviours. But actually, of course, what they do is keep the beliefs persisting. Because if you're doing all of that work, it means you don't get to find out that actually other people don't think you're boring, and that actually people would accept you as you are. So these behaviours are particularly problematic. So let's move on to think about what causes anxiety. And we know that there are particular predictors that are really robust. And the first is having an inhibited temperament. So this is where going into a new situation, you might sort of hold yourself back a bit, be a bit more withdrawn, a bit more tentative. You can see that even with very young children. You know, there might be a really novel situation. Some babies, you know, let's say you're going to a swimming lesson. There are some babies, aren't there, just throwing themselves into the swimming pool. There are other ones that are crying their eyes out. So we can just see that, you know, there's different hard wiring in terms of how children might respond to new situations, and that's going to be really important. In fact, having an inhibited temperament puts you at 7-fold increase of developing an anxiety disorder. So it's a really important factor. So we know that part of that is just sort of hardwired for us. But also the second most robust predictor is having a parent with anxiety disorder. That puts you at a 2-fold increase. So we very often see parents with anxiety problems as well. And essentially, you know, when we're thinking about how do we really explain what's going on with anxiety, of course, inevitably, it's going to be a complex interplay between having a genetic predisposition and various different environmental factors that are occurring at the same time. So we know from family, twin and adoption studies that heritability accounts for about 25 to 50% of the variance. But that means we've got another 50 or so % to play with that's all about environment. You know, there's been lots of research really trying to understand what are the risks of the particular genes that we can identify in developing anxiety. Sadly, there is no one gene, or maybe that's not a bad thing, but essentially it's really polygenic. So it's not that we can identify this gene and do all sorts of clever things to manipulate it. There's lots of different things in our genetic makeup that are likely to contribute to this, but it's in conjunction with these environmental factors. And because the high interfamilial factors that we see where, you know, we see anxiety in families, for those of you where anxiety, you know, is in your family, you will know that. You know, you've got a mum that's anxious, an auntie that's anxious, you will just be able to see that. And so for various reasons, there's been a real focus on parenting when researchers have been looking at those different family factors, amongst, of course, all those other factors as well. And particularly zoning in on this sort of idea of kind of helicopter parenting, if you like, this idea of being very over-involved and perhaps over-controlling. And in fact, you know, there's good data that does support this, looking at kind of experimental data and looking at data over several time points that can establish that there are particular parenting behaviours that do increase children's anxiety. But of course, it flips the other way around. It's not as straightforward as that. So a really anxious child will evoke any of us to sort of behave in particular ways with parenting. So there's some really lovely experimental evidence where you take an anxious child, bring in another parent, and that parent just starts behaving in exactly the same way. So you get this kind of reciprocal loop, essentially. So it's not as straightforward as that. And, you know, one of the things I think we really try to think about in our treatment is not blaming parents, you know, when we're thinking about problems that develop, because parents are just doing their best with, you know, in particularly challenging environments. So, who are most affected then by anxiety disorders? We see that children who grew up in poverty, not just in terms of developing anxiety, but in mental health problems more generally, they're at a fourfold increased risk by the time that they're 11, if they grow up in poverty, of developing any kind of mental health problem. And then we can see that all these other factors as well, so being from an ethnic minority background, having a neurodevelopmental disorder, physical or learning disabilities, being from the LGBT plus community, all of these things lead to higher rates of mental health problems just generally, not just anxiety. And in fact, Mars mentioned the CoSpace study that we did looking at tracking children's mental health during the COVID-19 pandemic. Just showing you a little bit of data from this. This was the first year of the pandemic, and you can see these three little graphs here looking at behavioural difficulties, emotional difficulties, and attention hyperactivity difficulties. And the grey-green line at the top is our children with special educational needs or neurodevelopmental disorders. The next one down in pink is children from a lower income background. All the way through the pandemic, we saw that their rates of mental health were above those of other children. So we see that in times of stress, but we also see it more generally, that these children are at a higher risk. Okay, so let's now start to think about what might explain the rise. And I think this quote probably sums up very nicely where we're at in terms of the evidence, but I'm going to walk you through some of where we're at in a moment. So this comes from Andrea Danesi at King's, and he says the causes of the increase are complex, and I'm not sure we fully understand them. It's the cumulative effect of a great many challenges rather than one in isolation that creates a perfect storm. Essentially, we've got really imperfect data when it comes to looking at this. There's an increasing literature that's starting to look at mechanisms to understand why anxiety disorders have increased. But we are far from knowing exactly what's going on. Lots of the data is correlational, where, you know, two factors seem to be associated, but of course you don't know what's causing what, or in fact whether there is a third factor that accounts for both of those. So we really lack the longitudinal experimental data that we would need to see to establish causality. And much of the research also is focused more generally on mental health difficulties or emotional disorders or internalizing disorders, but essentially is putting together anxiety, depression, and a number of other things too. So it's actually really hard for us to disentangle all of this. But when we're thinking about these factors, we're obviously thinking about factors at the individual level that put them at potentially increased risk, but there are also factors that are proximal to the child, much closer to the child, and then obviously some distal factors too. I do not have time this evening to talk you through everything, so I'm just going to pull out a few that I think you might be interested in. And one of the questions I get asked a lot about is social media and smartphones, so I thought this might be a good one for us to start with. So I'm sure you'll be aware that, you know, huge numbers of young people are using social media. It's 95% of young people who are age 15 are on social media. This Ofcom produce a report every year, Online Nation, and in that report they're describing social media use, and actually they're describing how young people report concerns about their own social media use. So we can see that in the survey down here, you know, as children are getting older, they're reporting having concerns about the amount of time they spend online and the impact that that might have on them. And actually, we as adults, I mean, the Ofcom report is very interesting reading. We're spending over 4 hours a day on social media. Young people are spending, you know, more than that. But yeah, for all of us, this is a huge challenge, I think, isn't it? So let's start to look at some of the data then. And this is Amy Orban, who's based at Cambridge University, who's doing a great deal of research in this area. And so I thought I would show you one of her recent studies. So this is a study that was published just last year, led by Lucia Fassi. And in this study, they wanted to look at the data over the last 16 years of research looking at the association between social media use and internalizing mental health problems in over 1 million teenagers. They were interested in looking at both clinical and community adolescent samples, but actually the vast majority of this is in community populations. It's not in young people where they've got kind of clinical levels of problems. Those studies only account for about 11% of this literature. So you might not be able to see this too well, but hopefully you sort of get a general sense of it. So this is the figure from this study looking at the time spent on social media. Each of these lines is a different study that was included in this meta-analysis. And then on the right-hand side, you can see some squares, and that gives you the effect size for each of these individual studies with confidence intervals. And then if we look here, you can see the overall effect sizes when you pool all of this data together. And so on this forest plot, we can see that this line where it says 0 would mean that there is no association. If studies are falling to the right-hand side, it suggests that actually time spent on social media is associated with increased symptoms. If it's this side, it's associated with decreased symptoms. So you can see overall that it's just on the right-hand side with effect sizes that are actually incredibly small. So this is looking at, it's R, so the range could be from 1 to -1, and what we're seeing are effect sizes of 0.08 for clinical groups and 0.12 for community groups. So it's a small association, which might be surprising, I think, to you. Similarly, this is their study looking at all of these different studies, and it's about social media engagement and internalizing symptoms. And again, you can see that when we look at the pooled effect sizes here, again, we're looking at small, significant, but small effects when we look at this association. So overall, when you look at the findings from these literature, it's really very similar to this. It's pretty inconclusive, very mixed in terms of the findings. And of course, it's likely that the relationship is way more complicated than just looking at the amount of time young people are spending online. It's inevitably going to be so much more nuanced than that. You know, for some young people and some subgroups, we know that social media is hugely beneficial, particularly actually many of the groups that we talked about earlier in terms of neurodiverse young people, LGBTQ+ young people. You know, for them, it may be really positive. So I think what's sort of moving forward is really trying to understand, you know, at the subgroup level, where is this not working, rather than this just whole general idea of social media is bad. It's really understanding about in what circumstances is it bad and what might be the mechanisms that account for that. And I know that flies in the face of you know, the report, the book by Jonathan Haidt that was very popular this year, The Anxious Generation. It's, I think, often very easy for us to want to look to one thing that we can sort of look to account for difficulties that people are experiencing, and it is clearly way more nuanced than that. So let's move on then to start to think about this is another sort of associated point, but you'll also be aware, so we've obviously got Australia banning social media for under 16s, and then there's a real push as well to take smartphones out of school environments. And in many ways that seems completely logical, doesn't it? The idea that actually in a school environment, you know, having young people using their smartphones might be associated with poorer mental health. But I wanted to show you this study because this study literally came out 2 months ago. And this study was based in the UK. And it was looking at schools where they had permissive smartphone usage during the day. So children were allowed to use their smartphones in secondary schools. And it compared the outcomes for restrictive schools where teenagers were not allowed to use a smartphone in the school environment. And they wanted to see what happened in terms of the outcomes. Just as with Amy Orban's study, again, they find this association, more time spent on phones and social media was associated with worsened mental health and well-being. But actually what is really fascinating from this study is they found no significant differences between these two school types in terms of the association with mental well-being, with anxiety, with depression, even things going on in the classroom, you know, academic attainment, disruption in the classroom, and then a range of other things. Essentially, the children weren't using social media or phones during the day, but actually, of course, then they would go home and then they would be using it, you know, in the evenings or at weekends. So actually, you know, you can take it out of the school day, but it probably doesn't make a huge amount of difference to those young people. And certainly with these policies, in the way that this was set up, they don't seem to be having a particular effect. So it suggests that if you are going to remove smartphones from schools, maybe those policies need a bit more of a look at to see how you would do that in a way that does have an impact on these different factors. Okay, so let's move on now to think about education. So, of course, there have been so many reforms over the last sort of 10 or 15 years in the UK, much more testing, grading, and as a result of that, there's been a lot of thinking that might be associated with greater pressure, greater stress for young people. And certainly, when we look at surveys like this one by BBC Bitesize, you can see passing exams and getting good grades is right at the top of what children are saying causes them stress. But also do notice this was done pretty much this week, 2 years ago. So there might be good reason to think that, during May, you would hope that actually people are quite worried about passing exams and getting good grades. So this hypothesis was put together to really try to understand what might be going on in Western countries. Is it the case that, in society now we're putting much more emphasis on education because of the nature of higher education being much more expansive, but also the sort of knowledge economy means that many more young people are increasingly dependent on education to get on in life, and as a result of that, that leads to them feeling a lot more stressed. So this study is an interesting study that again looks at a huge number of different studies to try to understand whether that might be the case, looking at over 150,000 teenagers across lots of different countries to understand whether this relationship might be the case. This just looks at school stress generally rather than the associations between mental health, and what you can see is actually a fairly stable picture when we look at all of these different countries. You can see that girls have higher levels of school stress in most of these figures, and that there's huge variability between countries, but essentially stress doesn't seem to have massively increased. But interestingly, what they do find is that when you look at economic change and educational expansion, that does seem to have a negative impact on mental health problems. And that becomes a stronger association as countries get richer and they get more educated. Okay, so bullying and cyberbullying clearly are likely to be part of the picture as well when we're trying to understand what's happening. In many European countries, there's actually been a downward trend in bullying, but actually it's really variable. And actually, one of the things that we've seen in the UK, in Scotland, is a study that's actually demonstrated that, if anything, bullying seems to have gone up over time. So this study was carried out by Alina Kozma, and again, looking at lots of different, really nice sort of number in terms of how many people it involved. It involved over 40,000 students in Scotland. And they first of all looked at the numbers who were experiencing bullying. You can see the lighter is 2004 and the darker bar is 2014. And you can see on the whole, looks like bullying has gone up, particularly in the younger populations. It seems to sort of be decreasing in age. And when they looked at the relationship with mental well-being over time, what they found was, particularly in girls, that actually over time they were reporting less confidence in themselves, less happiness, and more psychological complaints than the younger people that weren't bullied. And this effect over time, they weren't seeing that in the boys, they were just seeing that in the girls. So again, that might be supportive again of that being potentially part of the picture when understanding what might be happening with the prevalence data. In terms of family environment then, we have seen changes in family environment over the last 15 years or so. Many young people are not now living with biological parents in the way that they might have done sort of 20 so years ago. Actually, what we see though from that is that that doesn't really account for any of the changes in prevalence rates. But I mentioned maternal or parental mental health earlier on, and actually 2 large studies that were carried out, large longitudinal studies carried out, do find evidence for moderate influence of parental mental health, particularly looking at mums, where they saw that maternal emotional problems predicted increases in adolescent emotional problems over a time span. It's relatively early compared to the prevalence data I showed you earlier on. But what interestingly they saw is when they compared all the different cohorts, but they accounted for the increase in maternal emotional problems. Many of those differences were sort of much reduced. So again, this is likely to be an important part of the picture that we need to be thinking about. And finally, health and lifestyle. So, you know, we have seen changes over the last 10 to 15 years in young people's health and the kind of lifestyle factors. We see sleep problems have risen. Smartphones may well be a part of that picture. We see that physical activity has declined, and again, that's particularly the case since the COVID-19 pandemic, and obesity rates have risen. But actually, we're not seeing obesity particularly linked to a rise in mental health difficulties per se. But actually, there's some positive as well, because actually what we're also seeing is alcohol consumption and illicit drug use amongst teenagers decreasing over this time. We're also seeing a decrease in risky behaviour. So in terms of this data, it's way too early to say. There just isn't an impact of these trends that we can really pull apart in understanding what might be going on. And of course, you know, we've got to see this in this backdrop of really, really important wider social environmental trends. I'm not talking about those this evening, but that doesn't imply that these aren't really, really important. So, you know, insecure employment, housing insecurity, all of these different factors are things that are associated with mental health in young people, and again, are going to be a really important part of the picture. So, okay, what can we do then? So I'm sure we're all aware that there is a real problem at the moment in terms of the current crisis in services. There's data from the Centre for Mental Health that suggests on average young people are waiting 10 years between problems starting and actually seeking help. And then there are real problems in terms of accessing support, and partly that comes down to funding. We know 30% of our population are children and young people, but only 8% of the mental health spend is on this population. So there are inequalities in the spending that we have overall. And what we've seen since COVID is a huge increase in the number of young people being referred for treatment in child and adolescent mental health services. It's gone up 53%. And, you know, I know there's some clinical psychologists in the audience, and we are at breaking point, I think, within services, huge challenges to try to meet that demand. And this is a report by the Children's Commissioner, and it demonstrates that actually, you know, when we're looking at who's sitting on waiting lists, for many of those young people, they are waiting for treatment for an anxiety problem, and they're often waiting sort of 2 years or more to get that treatment. So how should we intervene? Well, clearly we need a whole approach that involves a range of different things, and that's thinking about all the way from prevention to treatment to continuing care. But I'm conscious of how much I'm trying to get through this evening, so I'm only going to focus on this middle bit, and hopefully I can do that in the time allotted, because this is really where we've focused a lot of our efforts. So in terms of treatment for anxiety disorders, the NICE guidance indicates that for anxiety, cognitive behaviour therapy, or CBT, is the first-line treatment approach. Actually, that's the case for many other problems too, but particularly for anxiety. And this involves a range of different things. So a typical treatment for a young person might involve, first of all, recognising their anxious feelings, what's going on in their body, and then it really zones in on the kind of unrealistic or negative thinking patterns and predictions that I mentioned earlier on. So all of these different ways that people might think in an anxiety-provoking situation that may not be realistic. And then it moves to start to test out these negative predictions, and that might involve some discussion, but also it will involve behavioural exercises, and typically that involves what's called exposure or behavioural experiments, where the young person is put into the situations. This is very collaborative. I'm making it sound like something is imposed upon them, but essentially they start to test out the ways that they're thinking about things by going into situations and starting to kind of create new learning. And it might also involve some other factors, like things like developing coping skills. Okay, I'm conscious of time, so I'm just going to actually jump over a few slides, but essentially these slides show us that CBT is effective. But you'll see that even though it's effective, actually we're still only hitting rates for about 50% of young people being free of their anxiety disorder at the end of treatment. And also that treatments actually are quite long. So you'll see that, you know, nearly a quarter of evidence-based treatments are sort of 20 plus hours, and actually over 50% of them are 10 to 20 hours. So we've got huge waiting lists, a huge amount of demand. And so for those reasons, the focus that we've really been trying to kind of zone in on is how do we develop efficient, effective treatments? How do we do them in a way that does not lose effectiveness? If anything, can we get better? So in the remaining time, I'm just going to talk a little bit about the treatment approaches that we've used. And so for primary school age children, the focus that we've particularly taken, and this has all been led by Cathy Creswell, my colleague in Oxford, has been taking a parent-led approach. So with children primary school age, actually what we find is that if we work via their parent, that can be just as effective as actually getting children attending sessions as well. So this involves the therapist working with the parent. The child doesn't even attend any sessions. They might come in for the assessment at the beginning and perhaps at the end, but essentially they're left to get on, go to school, do all their normal things without coming in for treatment. And essentially the benefits of that is that, you know, parents are empowered. Often they have multiple children, and therefore, you know, they learn skills that they can apply to their other children, to themselves. And actually, by coaching parents, that can be really effective. So the parents then learn how to deliver the CBT to their children. It's about the parents learning and developing opportunities to test out fears with their child. It's structure and goal focused. And really, it's about taking a very problem-solving, curious approach to think about what they might need to learn. And so Cathy Creswell and Lucy Willets wrote this book many years ago, Overcoming Your Child's Fears and Worries, which was then updated to the later version of this book, Helping Your Child with Fears and Worries, that I am one of the co-editors for. And this has been used to treat parents very efficiently, because actually getting parents to read the book and then having these sort of adjunct therapist sessions becomes a very efficient way of treating anxiety. So this is the results from the very first trial, and you can see that actually using this approach, so there were two different versions, a brief version of 2.5 hours and a longer version, that actually by the end of treatment 50% of children no longer had their anxiety disorder, and that goes all the way up to 75% 6 months post follow-up. So that's a vast improvement on what we're seeing from the meta-analyses that pull together all of these different studies, but actually in a vastly quicker way. And then more recently, that's been developed into a computerized approach. This is Aussie, and that has recently been evaluated. So this was a trial that was undertaken and was published last year, where we evaluated it. This funding came from COVID funding, actually, where we were commissioned to evaluate this in sites across the UK, across England, really trying to understand whether this treatment is effective as treatment as usual. And just flying through these slides a little bit, but essentially they showed that it was actually, it wasn't inferior in any way, and actually using this much quicker treatment, if we look to the graph on the right, you can see that actually those two lines, treatment as usual and using Aussies, are really very comparable, and that's on both child and parent report. But this is, in some ways, the kind of big take-home picture from this is that actually it's much more efficient by delivering it this way. So what we find is that when clinicians are delivering Aussie, they can do it in 59% of the time that they would be using if they're delivering treatment as usual. Actually, what we also found from this study was that treatment as usual often was a parent-led approach. So it looks like that concept is being adopted, but using a digitalized treatment allows us to do it in a much more efficient way. And these were some of the quotes coming from parents describing the benefits of using this kind of digital intervention with therapist support, where, you know, they could be washing the dishes and listening to it, or they're in bed at midnight and engaging with it. You know, parents are super busy. And so if we can get interventions that are easy for them to use in their life and then use the therapist to sort of support that, then that is a really nice way of delivering treatment. But actually, we're using a different approach with our teenagers. Working through parents is not going to work for our teenagers. You know, I've already talked a lot about, you know, they're presenting with much more severe problems. But what we know from our adult colleagues is that actually using a more cognitive approach can get really good outcomes. So for adults using cognitive therapy, we're in the sort of ballpark of kind of 80% remission rates rather than that kind of 50% that we see. So this is the real focus that we've had recently in our research group. So I'm just going to tell you about two studies before we sort of round things up. So this is a study by my colleague Eleanor Lee, Really focusing on social anxiety. As I mentioned before, it's a primary problem, actually often very challenging to treat. The clinical psychologists in the room will know that actually often the outcomes for social anxiety treatments have historically been poorer than other kind of anxiety disorders. So this treatment is a digitalized treatment. It involves 14 weekly online sessions and 20-minute phone calls with the therapists. So actually the young people are actually doing quite a lot of work. You can see that they're logging in for about 26 hours. But from a therapist's point of view, the therapist is providing just 6.5 hours of support time. So it's very efficient for delivering a lot of therapy and really targeting how the therapists are used. And you can see on this graph, compared to the waitlist in blue, we've got the green line, which was the treatment group. 77% of the young people lost their diagnosis post-treatment, and this went up to 91% at the 6-month follow-up. So this kind of approach is really exciting because it's efficient, it's deliverable, and it actually gets a lot more people better at the end of it. And similarly, we've finished a trial a couple of years ago. We're just writing this up now, focusing on teenagers with panic disorder. And this is a more pragmatic trial, actually. It's a feasibility study, not powered to look at statistical differences, but this involves using routine therapists. So these are not highly trained, super duper therapists with years and years of expertise. These are therapists working in routine clinical services with 1 year of CBT training. They're a really brilliant workforce. And so we compared cognitive therapy with these workbooks, 5 sessions to a general CBT approach. And we were interested to look at a range of different factors like, can we recruit young people? Is it feasible? Is it acceptable? And we were also keen to look at what the treatment outcomes looked like. And actually what we found is we met all the feasibility criteria. We had very low levels of dropout, and all the qualitative data suggested that it was highly acceptable. And these two graphs show you the different outcomes. So this is our general CBT and our brief cognitive therapy. Each of these lines is an individual patient. You can see that actually the direction on both graphs is generally a downward trend, so people are improving, and actually there are large effect sizes in both treatment arms. But what you can see in brief cognitive therapy is that actually everyone reliably improved compared to this graph, where you can see that many people did, but also there's a substantial number of people that didn't improve. So it may be that we can use these more targeted approaches more effectively. And so just to sort of finish up a little bit, this is a really nice quote from a young person just describing the impact of therapy for them and how for them they feel like a new person. They're able to do all of these things that they weren't able to do prior to having treatment, which is really exciting, that we can really change the life course for young people like this. So just to kind of round up then, what can we do? Well, these are challenging times, aren't they? But I think there are a number of things we can do, and one of which is really help our young people distinguish between what is normal stress and anxiety and what is a mental health difficulty. It's normal to feel intense emotions. It's normal to feel stressed. And, describing things in a disordered language, may actually be really unhelpful for young people. It's really important to support them to deal with problems. That's about listening, all the, those good parenting strategies, helping them to problem solve, being empathic, but really pushing them to learn coping skills in the face of challenges and building self-confidence. That idea of exposure, pushing yourself to go outside your comfort zone is really important. But of course, for some of those young people, that won't be sufficient and they will need support, and we need to help them be able to access professional care. And in terms of these increased prevalence rates, in many ways it's about recognizing that, there are many unknowns. We can see that some of these factors, that we've talked about earlier on, do seem to be important. But the data is limited and there is no one easy answer. There are many things that we need to address at that sort of distal and proximal level. There are things that we need to do in terms of social media platforms, but perhaps banning them isn't the answer. It's about helping young people use them and kind of get to grips with them, and how we support parents to support their young people around social media use. And of course, supporting parents around their own mental health is clearly going to be important too, and addressing all of those school factors that we know are likely to be important as well, working with all those key stakeholders, identifying people early, improving funding and quality of mental health services in order to be more efficient and more effective in how we target treatments, with the idea that hopefully by doing that we can really increase young people's opportunity to kind of live their life and reach their full potential. And I better come to an end at that point. So thank you very much for listening.
So we have time for questions. So questions for Polly. Yes.
I'm the parent of a child, well, he's now 31, who had terrible anxiety problems and had to take a year out of Oxford. It evidenced itself as anxiety trigger just to stay in bed a long time and not doing anything.
Yeah.
And he did get his degree and now in the civil service. He still sees a therapist. But when I asked him why he and so many, and he's LGBT, he's gay, so that was interesting. Why what's the cause of anxiety in him? And so he just says screen time, not just screen time.
Screen time.
That's it.
Yeah.
And he says that's the thing that's changed. Now, of course, the increase in screen time, I suppose, is across the board. But as a fairly academic child, not very sporty, he probably spent excessive amounts of time on screen time, which means he's incredibly knowledgeable, very bright. But his social interactions even now are still quite anxious. And people get, well, how do I go with this? And the question is often banal to answer.
Yeah.
But he's getting better. But it's the rise in screen time.
Yeah.
That is such not just socially, it isolates you from normal interactions that people of my generation and others didn't have screen time.
Yeah. Yeah, that's true. I mean, I think, we can see that from the data, but we could also think of screen time as kind of an avoidance safety behaviour, couldn't we? And it might be that for some people, using their screens is one way of avoiding social interaction. For another person, there might be another, way in which they don't necessarily engage with other people. So it's clearly complicated, isn't it? And I think, in a way, the idea that we might get in there early with things like parent-led treatments is really appealing, because for many of those young people, actually, you can see it, relatively early on, and then it reaches a crunch point later on. It's a really important time of life, and you really feel like, had you been able to get in there early and set some particular things up, there might have been advantages. And Oxford is a challenging environment as well, isn't it? There's a lot of pressure for the young people, and so it's really about thinking about how do we support young people to manage particularly challenging, pressurised points in their life too.
He was very critical. He said he wanted someone seriously bright. He must have inherited my wife's intelligence, who to do, because he could see through some of the things. So they're not doing. And he found the right people and worked through it.
Yeah. And we're very lucky now. We have very good mental health teams and supports within college, and but ideally, the earlier we can get to this, the better, I think.
Well, the new college.
Can you hear in the back questions? Yes.
So I would say two things. One is, I'd like your opinion on whether anxiety has increased or just the ability to measure it has increased. But also, I like your parent-led approach. But can it be tailored so it could become a child-led approach, so you don't need to involve as many professional outsiders, so they have tools to help themselves?
Okay, great. It's two good questions. I mean, I think clearly there is many more people now recognise problems that they might not have recognised, and that's across the field. We can see that with neurodiversity, can't we? I mean, the amount of adults that suddenly realising that they are neurodiverse that never had a way of understanding it before. And I think that's the case with anxiety. The more we talk about it, the more people realise, that is me, and understanding it from that point of view. But I think that prevalence data, the way in which that study was conducted, would suggest that actually it's not just about that. The fact that we don't see those increases in other disorders, the fact that we do have these associated increases in things like presentations in A&E. So I think we are seeing genuine increases in prevalence as well as greater understanding. In terms of developing tools, could we, for primary school age children, just focus on the child and not involve the parents? I mean, some researchers have gone in that direction. So, we'll go to conferences and there'll be presentations from others of our colleagues saying, I've got this great new treatment, you don't need to involve parents at all. But we think actually working through parents is a really effective way of doing it, because, the opportunity for them to generalise, and, it's very, I mean, a lot of parents will realise how hard it is to get anything out of your child. So it's all very well your child having these sessions, but your ability to sort of understand them and support them in that can be, can be difficult. So I think there are advantages in working through parents. And actually the parent-led approach was developed because there were studies where they were doing both parent workshops and child workshops. And then they realized when they took the child workshops out, it made zero difference to the outcomes. So, so then, you know, there's really no point essentially doing that. But I think when it comes to teenagers, very much so, it is really about teaching them the tools. So, you know, that's a really golden opportunity for them to actually, you know, have a toolbox that is self-directed, that they can use throughout their life in managing challenges. No, they don't, and rightly so. So, yeah, absolutely. So, and that's not to say parents aren't involved with our teenagers, but we just, you know, we work out how we're best off using parents, because there have been lots of studies where you then, it sort of flips the other way with the teenagers. You can do lots of parental involvement. We did a study a number of years ago where we gave parents all of these extra sessions because intuitively you think that's going to improve outcomes. It made zero difference giving all these parents extra sessions. And some of the trials where they got the worst outcomes is where they're doing everything with everyone. And it's this sort of scattergun approach. So instead, what we tend to do is really focus on the teenager, but we're also having half an eye on what's going on with the parent, because we're looking for how can they reinforce, you know, these good things, and how can they be supportive of that. But we're trying to do it really efficiently. So I think it's different things at different ages.
And lots of hands. I'll try and go around the room a bit. So, yes, please.
It's great news about the research you've done, because an increasing number of people aren't going to see therapists one-to-one, and so you need to do it through groups and so on. So I'm glad it works. The question I had was, at the moment in my trust, we're seeing about 50% of people who are referred within a year. I think that's quite normal. So there's a very large population of people who have been diagnosed but aren't getting any treatment. And I just wondered, what's the spontaneous change rate? Because especially in adolescence, children are changing all the time.
Great question. I mean, if going back to the James et al. Meta-analysis, it looks like it's about 20%. So actually, when you have waitlist controls, you know, it really varies. But some, you know, that pool was about, I think it was 18% actually. So there is some spontaneous remission, and you know, and studies are never reporting on time span. It always intrigues me, a bit like that data where you think, well, of course they felt like that because they were just in the middle of their exams. So, you know, inevitably it is like that. So I think that's an important factor. There are many ways of trying to get at how do we hit the numbers at the level that we need to, and where the sweet spot is in terms of effective treatment but efficient treatment. So I've got colleagues, you know, Maria Lodes in Bath is working on things like single session treatments for depression, and can you streamline it even further? You know, obviously there are other implications of, can you get things into schools? Can you do intervention early on in terms of, you know, prevention? That's really mixed. So, you know, a lot of researchers have been, you know, really interested in universal prevention. Can we get into schools? Can we deliver these programs? And what we see is that in some instances you can, but what we've also seen in a couple of trials, of prevention trials, is that actually makes some people worse by universal prevention. So there's a big study that was published relatively recently on mindfulness in schools, the Myriad study, and they found that actually a significant minority of young people who had pre-existing anxiety and depression actually were made worse having mindfulness in a school environment. So it's so complicated. There's no easy answer to this. How, you know, but I think what we need to think about is that everything that we do has the potential to improve but also do harm. So we need to be really careful in what we're doing, that the whole time we're thinking about that and we're measuring, rather than just thinking this is really logical, or of course it's going to work like this, because sometimes it doesn't, and we need to sort of be thinking about that.
In the middle, then we'll move to the back and we'll come down to the front. So, yes.
Me?
Yes.
I work with year 3 to 6 in behaviour trauma in schools and education. So obviously this is a little above, but I'm very interested in what you're saying about the parent-led, because the area that I work in is a lower earning bracket, so the engagement of parent-led, especially when you're drawing down and scaffolding down to primary age, is critical from what you're saying. And I unfortunately see a lot, specifically in years 5 and 6 at the moment, who cannot get onto that CAMS study, so we're being used almost as the buffer and Tala. So you're holding that space to empower them to get it out. So you just said to the gentleman then, you're obviously bringing it into schools. Is there any plan on the scaffolding of coming from this study into the LA to get it accessed into the school programme?
Well, I mean, actually, there's been lots of really interesting work and spin-offs from the COCAT study. So actually some really early intervention going down. I can't remember what the years were, but it was sort of like 5-year-olds and working, you know, ideally before anxiety problems persist and become bigger problems. So I think, you know, it's been demonstrated to be deliverable by pastoral workers, so it doesn't need to be sort of therapists. So I think the idea is, how do you scale it up, get it in different environments and that kind of thing. But
because every team and every SENS school team is desperate to be able to know what intervention can be there to hold these children, to allow them to be nurtured, to learn in an educational environment. So kind of grappling.
Yeah, exactly. So I think it probably is about trying to get these approaches out more broadly. I mean, interestingly, the more recent study that hasn't been published yet, but they also felt like schools were really saying, can you do something with us? Could you come in and do some workshops with the children as well? And what they found from the study is that the parent-led approach actually reduced the children's anxiety, but the child workshops seemed to increase it. And that might just be an artifact of spending a lot of time with little children talking about anxiety, and then it becomes sort of everyone thinks they've got anxiety and they're filling in their questionnaires. So again, it's just how do we do that? And certainly kind of more indicated selective approaches in schools, you know, probably are the way to go, rather than just going in and, you know, what we're not interested in is making happy children even happier. We want to help the children that are really struggling. And how we do that. So I think we're learning all the time, but some of the things that you logically think might not always be the case.
Far end of the same row.
Thank you. You mentioned parental over-involvement being one of the predictors of this. Good parents want to be involved.
Yeah.
Can you unpick what elements of over-involvement, which bits there are causing the problems?
Yeah.
We know?
Yeah. So I think essentially it's when parents are stepping in and sort of doing things for their child and not giving the child the opportunity to learn for themselves. So, you know, so actually I think as a parent what you're wanting to look for is opportunities. Sometimes it's so much quicker to do things for your children. And actually it's sort of trying to seek out opportunities to get your child doing things for themselves, to give them that sense of sort of self-efficacy and confidence. So that might be any, you know, all different aspects of getting your children cooking more independently than you might think, gosh, that looks slightly dangerous. But, you know, it's all of those things of, you know, pushing your child to do things where they're going outside their comfort zone, they're making mistakes. You know, and they're learning from it, and they're learning that it's okay. And so I think, you know, across different levels, it's about doing those things. So when, you know, if you've got a clingy child and you're going into an environment, rather than trying to sort of withdraw and facilitate that, is how you sort of encourage them to do particular things. So yeah, so it's those kind of behaviours that yeah, particularly have been shown to be.
Okay. Same row, then I saw two at the back, and then 1, 2, yes. Gentleman in green? No? No? Okay, at the back? Yes.
Yeah, hi, I'm an educational psychologist. So I'm in schools day in, day out. And the thing that's good to hear about the treatment working, obviously that's great, parent-led, you know, let's be more efficient by all means. But it's quite hard to hear when the access for so many children, so many schools, is so limited. And it's almost frustrating as a professional working in schools to see that option there, but it not be accessible.
Yeah.
And actually for the proximal and the distal factors that you've identified, they're so important.
Oh, yeah.
And they're so interactive, but particularly the distal ones. The state of mental health of staff in schools at the moment.
Yeah.
Means, from political reasons, is having a huge impact on the children's well-being. And yes, of course, it's individual needs, but it is also the entire context. And I just feel that it's great, but it's just not quite.
And I wouldn't even dream of arguing. Yeah, this is one part of the jigsaw, isn't it? And it's, you know, it's not about saying that this is the panacea and this is what we need. It's about understanding how all of these things fit together. I know it's super challenging. I mean, I think one of the exciting things about the Aussie program and the parent-led approach is actually, you know, is that the team are working with developers to get this into services, because the danger with a lot of these treatment studies is that, you know, this gets funded, somebody demonstrates it's effective, and then it just disappears into the ether. And that happens so many times with digital treatments. But actually, at the heart of the Aussie programme is actually getting this out there. So it's now being commissioned by NHS services, you know, in a widespread way. There's a push to get it out into mental health in schools, teams. So I think increasingly, it's about how you get that so it's accessible. And that's not just through health services, it's through, you know, social care, it's through education.
Schools have mental health in schools teams, but the children are able to see them because they say, oh, sorry, you're too complex.
Yeah.
So they're really falling between two stools.
Yeah.
Okay,
No, you're right.
Yeah, let's give someone else a chance. I saw another hand at the back, I think.
Oh, well.
Oh.
I had a few things to say, but I'll just say one.
Or just one, please.
I don't know if you followed Dr. Chatterjee on the podcast at all, but he had something the other week about that maybe there's a case of over-labelling, and then people try to live up to it and see if the label they've been given.
Yeah. Yeah, I mean, I think that's very much the case, and I think that's one of the kind of key points is how we help young people derive sort of positives from, you know, other labels. I mean, in the panic trial, actually, we had one young man who was in the trial who very much his identity was about having a mental health difficulty, and I remember being quite worried. Actually, he turned into the biggest champion of CBT. It was just, you know, he basically learned skills to sort of manage his panic attacks in a different way, and actually he then was able to sort of take that and kind of, you know, generate it further amongst his friends and other people. So actually it can flip both ways, I think, where people can then, that is their identity.
I guess it has to be like just make it a smaller part so that you have to
yeah.
focus on positive things.
Yeah, I think that's exactly it. Yeah, yeah.
Thank you. Your information is great on a lot of children and adolescents that have obviously accepted different sorts of help. But there are a lot of children who won't, and adolescents who just won't accept that.
Yeah.
How do you go about dealing with them, or can you not deal with them?
That's a really good question, and I think
What was the question?
the question is, how do you help someone when they don't want to be helped, or they're not, you know, they're not at a point? And that is a challenge because, you know, if somebody won't engage in treatment, then actually it's absolutely fundamental. You can see what CBT involves, and actually the person has to be willing to engage in it. Sometimes it's about spending time thinking about the kind of costs and benefits of staying the same versus changing. And, you know, part of that early approach might be about how do you motivate and engage somebody to feel hope and to think that things could be different. But sometimes that might not be possible. And I guess in those instances, you know, there's a call to be made of, can you, again, work with family members where you might be able to change things peripherally? Or is it about waiting for a time point where that person will engage? Or is it about using a different approach, like medication or something else that might be, you know, that person's choice at that time? So, yeah, that is a real challenge.
Okay, I think two more, this gentleman. Maybe three more, you, and then one more hand.
That was really interesting. My name's Richard. I'm a father of two children, a 7-year-old and a 5-year-old. I've spent a bit of time looking at Jonathan Haidt's work because it's topical for the age of my children.
Yeah.
Just wondering what your thoughts are on why his work around presenting evidence for the relationship between rising social media use and smartphones has taken such hold in the public psyche. If when you look at Amy Organ's work, it doesn't seem to be that causal relationship.
Yeah. Yeah, because, I mean, it's interesting. So Jonathan Haidt's work, I mean, it has had huge public focus. And I think many people working in this field feel that, you know, a lot of that data is correlational. And therefore, you know, there's an overclaim in terms of this. I think for all of us, you know, we kind of want solutions that are easily implementable or things potentially to blame. And in some ways, you know, some of those bigger systemic issues that actually as a society we really need to address, they're challenging. And being able to put it onto one thing, you know, in some ways potentially feels easier. I mean, I think we've got a history of doing that where we were very preoccupied by video games, you know, 15 or so years ago, and Tanya Byron was, you know, involved in writing a report. I mean, there's always something that I think we often focus on to try to understand mental health and get particularly preoccupied about. That's not to say it's not a problem, but I think, you know, in a way, focusing on that at the expense of other things, in a way, means that, you know, it neglects all of these other factors that are really important in thinking about as well.
Hi, I'm a trainee psychologist working at the Tabby at the moment, and I work with families and a lot with parents. And I was curious about the reason. I agree with you. I think it's really important to involve like the whole family system and parents. I guess what I was curious about is the research on the parent-led programs. Do you know what demographic that was with? Because I work with it, knowing that the impact of poverty.
This is a great question.
Yeah, and I just was curious about how relevant and accessible it is
Yeah,
for parents.
really good question. Yeah. So one of the interesting things about Aussie, I mean, obviously you need to make it accessible to people that don't have smartphones. So there are various ways in which you can do that for people, you know, on lower incomes. But, you know, that ultimately that's going to be a barrier potentially for some families. And actually one of the things that we found with the qualitative data with that approach is that for families, for example, where parents had English as a second language, they actually really loved it because they could then get it to play out loud to them. They understood it, they could go back and play it. So for some families, actually, having a digital approach can be helpful. But it's not going to work for everyone, and we could see that with the qualitative data. You know, some parents were saying, you know, actually I'm too exhausted, I haven't got the time, I feel there's too much pressure on me. Or there would be families where parents are separated, and one parent might say, you know, I'm trying to use this approach, and the other person is not on the same hymn sheet, and that is a real challenge. So, you know, it's not going to work for everyone, but we've got a DPhil student at the moment, Emily Whitaker, who's really digging into the data to understand who this approach doesn't work for, and then how can we develop that further. So actually, you know, this is an evolution. There's a version that's just been developed for autistic young people. They've been working on it for years, actually, with Jonathan Green in Manchester. So we can also, you know, adapt the treatment, you know, to be more applicable. It may be for particular families. Again, there are certain things, just like the Aussie for Autism treatment, that might need to be adapted. But also, we just need to accept that nothing's going to work for everyone. And if we can figure out really early on who we should offer what to, then we can make best use of people's time and therapists' time too.
Thank you.
Yeah.
Last question.
Thank you. Yes, I absolutely hear what you say about the mindfulness impact. And it just made me very concerned because I just delivered a workshop to 56 formers to prepare for exam stress. So I'm very worried about the patient effect, but was actually really good. But I do get a lot of calling from teachers wanting to do this, and surely from an efficiency point of view, if you can allow this to filter down through teachers, you're capturing 30 children at a time rather than parents. Do you see a sort of CBT problem solving very specific rather than a mindfulness program?
Again, these are great questions. So we've had a PhD student, Helen Manley, who is a teacher, who has exactly that train of thought of, like, we need to get CBT sort of just embedded in the curriculum and teacher training, and then teachers using CBT principles in their classroom so that, you know, when there are anxiety-provoking situations, how do they encourage people to kind of engage in that? But one of the challenges is kind of implementing it. So Helen's done loads of work, developed sort of teacher training, but of course for schools it's really challenging at the moment because they, you know, like you were reflecting up there, they are so resource pressed, and the real challenge is how do we get this to teachers? And that is a real problem at the moment. So actually, you know, getting teachers engaged, getting them to have the headspace and the time to kind of embed these principles is a particular challenge right now. So I think this is a really obvious thing to do, and there are people working on it, but inevitably it's not as straightforward as you would like it to be. You want teachers to go, this is amazing, right, we're going to do all of these things, and, you know, they can't. So, yeah.
Okay, very good.
Very good, Holly, thank you. On behalf of the New College Society, I mean, it's a great privilege, genuinely, to, you know, have the fellows of the college come here and give us the benefit of wisdom. And it's particularly difficult, I think, to tackle a subject where you've got extensive professional interest in it, very strong views from parents of all ages, and I dare say, general interest. It's also great just to see such a wide age diversity that we have here. I mean, as a society, as the Alumni Society, it is our aim always to try and attract as many people across the ages, and you've done that for us this evening, and it's been a fascinating talk. Thank you very much.